Thanks, John. I'd like to thank John for the invitation as well as the other organizers, but that's exactly right. This is obviously a cancer we know for a few decades now that over 90% of all patients are cured. And you look at early stage disease, it's over 95%. So this is one we definitely want to get it right. It's also one you could say we want to split hairs and look at every case in a detailed fashion. And so I'll really concentrate on the first two bullets there on early stage and advanced stage. I was charged with talking about mainly newly diagnosed patients. And really the bulk of it and what most of the trials over the last 10 years have been about response-adapted therapy. I'll talk just real quickly on a couple niche topics of elderly or older patients with Hodgkin lymphoma, gray zone lymphoma that sometimes is thought about because it does have some Hodgkin-like features, and then just a couple slides on novel agents, although Dr. Eunice did a great job of that. So again, a lot of the talks have talked about definitions and how do we define, and I think it's important, again, in a disease that is highly curable, in talking about the definitions. And so, at least outside of the U.S., most of the studies, especially the German Hodgkin study group and EORTC, where most of our randomized data come from in the last 20 years, split early stage into two groups, using the definition of favorable or unfavorable. Some might interchange intermediate for unfavorable. And your early stage favorable, if you have stage 1 and 2 with no risk factors. One or more risk factors, you move to the other group. And so what are those definitions? Well, at least according to the German Hodgkin study group, you can see if you have one or more of these, you fall into the other group. So bulky mediastinal mass, extranodal involvement, high SED rate, over 50 in the absence of, or 30 if you have B symptoms, and one or two sites. In other words, if you have 3 sites of disease, you fall into the unfavorable. The EORTC differs. They don't use extranodal. They use age over 50 or 50 or greater. And they use more than 4 sites. In other words, if you have 3 or less. But a real devil in the details, again, you have to get into the details. Actually, what are sites? So most of us are used to this map of sites. The Cotswold at JCO, you can look it up, Lister first author about 25 years ago. And so cervical is a site. Supraclavicular, you can see, falls into that. Infraclavicular is a different site, etc. But interestingly, I think there's some, not so much misconception, but maybe appreciation. If you look at the German Hodgkin study group, they use a different definition of grouping. In fact, it's a much wider swath. And you look at, for example, the HD12, German Hodgkin study group, that one group for them, someone could have cervical, supraclavicular, infraclavicular, that's one site in the German Hodgkin study group. So even though it's different, it's at the end of the day probably ends up similar. But I think it's a very important detail if you're going to segregate into favorable, unfavorable. And this is, of course, buried in a supplemental appendix, so it's not always quite highlighted. And also, for example, you could have bilateral hilar and a mediastinal. That would be 3 sites in the EORTC or other in the Cotswold, where in the German Hodgkin study group, that's 1 site. So this is that aforementioned trial, the German Hodgkin study group, where HD12, where the arm on the far left was a standard for ABVD, 30 gray involved field, 2 by 2, knocking the chemo in half, was the experimental arm for chemo 4 to 2, and the involved field to 20 gray. And the long story short, for the chemotherapy, again, you don't need a statistician for this, it was overlapping. And for the 20 gray versus 30 gray, it was overlapping, where you ended up with 4 arms all overlapping. Again, early stage favorable. So the least amount of treatment, 2 ABVD and 20 gray involved field, was the same basically as 4 and 30 gray. So that's a I wouldn't say it's the standard, but it's an option if you will consider that. Again, 2 ABVD, 20 gray for favorable according to their mapping. What about the companion study to that came HD13? So this was the next iteration of studies that looked at, again, stage 1 and 2 without risk factors. And they asked a different question: can we start deleting drugs instead of less number of cycles? So you can see you started dropping dacarbazine in 2 arms and bleomycin in 1, and both in the 4th arm on the far right. And so early on their pre-planned analyses, these 2 arms, there was more than 10% relapse rate. by definition, they were looking there, in these non-inferiority studies, you always have a preset margin. They were looking at greater than 5% for these non-inferiority. So these were well over. The study continued, basically the ABVD versus AVD, and it didn't get a lot of press. It was actually published last year, as you can see in the bottom left in Lancet, about a year ago. And officially, by the preset criteria, in the AVD, no bleo arm, there was a 4% difference in freedom from treatment failure. Germany uses that endpoint often. But the boundary crossed 5%. So officially, statistically, it was rejected, so to speak. But you could argue, is a 4% difference in FFTF, there is no difference in overall survival. So at least in the German eyes, they're very hardcore statistically. Bleo remains in their treatment. What about unfavorable, which was the HD14? I'm not showing the HD11 that did 4 of BIACOT baseline. They decided to look at 4 of ABVD versus, you could say, 2 and 2. So it's 2 cycles of escalated and 2 cycles of ABVD. And this, according to the preset definition, was superior, at least in terms of FFTF and progression-free survival. You can see the differences are a little less than 10% in terms of these acute outcomes. So that's the current standard. If you were anyone in the room was in Germany and was diagnosed with unfavorable early stage, this is what they would recommend. So, this isn't a debate, but again, I would argue we should debate ourselves in every single patient, and it should not be one size fits all. We should involve the patient in the discussion on what is the best therapy. Well, this is a common debate of do you consolidate with radiotherapy or not, which the trials I just showed did not ask that question. Before response adapted, there were 4, I think it's very important baseline data, there were 4 randomized early stage studies. And what did those differences show in terms of absolute improvement, whether it was FFP or EFS? You can see 3 to 8%. Overall survival similar. There was the one extended follow-up NCIC ECOG study that actually showed better overall survival for chemo alone, although an older radiation therapy extended field was used. There was a meta-analysis done of the 8 German Hodgkin study group, 2 studies, and that NCI study, and again, comes out right around 6%. So this is before response adapted. You can see 3 to 8%. And another way to look at that, which I don't think we use this enough, maybe in lymphoma or cancer for that matter, it's not as if every patient had a 6% benefit. There's a number needed to treat. So in other words, you're treating 17 patients with radiation to prevent 1 relapse. Is that right? Is that wrong? I don't think there is a right or wrong. There's a lot of bias. Often you'll have medical oncologists on one side of the aisle, radiation oncologists on the other side of the aisle. But again, 3 to 8%. So that's important as we dive into the response adapted. And this was the study that we all jumped in the deep end, for better or for worse, that was published almost 10 years ago, where they showed irrespective of your Hassan-Cleaver score, IPS, if you had an early negative PET and continued on ABVD, it was predicted majority would relapse. Conversely, if you were negative. One subtext to this, the high majority of patients in this study were advanced stage. It's actually not a lot of early stage data that led to us jumping in, but again, we went ahead and jumped in. Another really important point, devil in the details, again, is where do you draw the line of your positive, negative? Dr. Coleman alluded to the Deauville score, and that should be a 1, 2, 3, not a 1. But most early stage studies, there is one alliance that I'm not going to show, but most have drawn the line between 2 and 3 in terms of negative versus positive. In other words, if you're more than the mediastinal blood pool, you're positive. And if you're less, you're negative. And what this does, by drawing the line there, it enhances your negative predictive value. In other words, you're making as much as possible that you're negative. If you start to move it down, it will increase your positive predictive value. So again, this is where the line was drawn for the 2 big randomized studies that are published. This was the first. Again, just to show you which patients were included. EORTC, German Hodgkin's, they divide favorable, unfavorable. Again, that different definition. Large study, over 1,000 patients. I wish we could do this in the U.S., almost half and half. And I won't go through in great detail, but it wasn't maybe the cleanest randomization, because it was a randomization to standard therapy, which is no PET, or randomizing to response-adapted therapy. So you weren't randomizing based on a PET, you were randomizing to strategies. And you can see for the favorables, they gave 4 total if you're PET negative, and they went to escalated BIACOP if you were positive. Same paradigm, but more chemo. And you can see in the PET negative experimental, 6 total, and the same actually in terms of the PET positive, 2 and 2, which is, again, remember the German standard. And so it's all in the statistics. This was another non-inferiority, and we can argue with where they drew the line, but they said they will allow up to a 10% decrease in progression-free. And they used the benchmarks of 95 and 90% for PFS, favorable and unfavorable. And what happened? Well, there was as many of these randomized studies, there is a data safety monitoring committee. And when they looked at 1-year outcomes, before I show that, these were the PET negative rates, 86 favorable, 75% unfavorable. But at 1 year, and it wasn't absolute, it didn't cross the 10%, but it was predicted that if the study continued, it would highly likely pass the pre-specified 10% rule for the arm that did not receive radiation, or to the experimental arm. So granted, the absolute numbers were small, but it was statistically rejected as not non-inferior. And basically, the null hypothesis, another way you can say it was rejected, or there's futility, and so everyone reverted to the standard arm, or at least adding radiation based on their, again, predefined statistics. What's the other study published in New England Journal last year was the RAPID study. So they didn't separate out favorable, unfavorable. They're all in one group, for better or for worse, and so arguably a cleaner study. And it actually wasn't an interim scan, even though we sometimes say response adapted. It actually was an end of chemotherapy. They gave everyone 3 cycles of ABVD, and if you were PET negative, randomized. 30 gray involved field, no further therapy. So I'm not going to get into some of the statistical, but if you're looking at a non-inferiority, you should actually it actually is recommended to look at the per protocol. It's the same reason, but conversely, why we look at an intent to treat for a superiority study. But when looking at the per protocol, so this is in PET negative, radiation, no radiation, there was a difference. Again, we could argue that, well, was this the right, does this matter? But what we were trying to do with these studies, I think, was a valid goal. The hope was in PET negativity, there would be no difference in acute PFS. There are those pre-existing biases that does this 7-8% difference matter? But at least for the question we were asking, or they were asking in these studies, it was this again, and it was stated it was not inferior. So again, these are my conclusions, trying to be as data-driven as possible, that it's not proven to be predictive. And I think that's also another assumption, that just because a test is prognostic, meaning it might, based on pre-test probabilities, it doesn't mean it's predictive, meaning based on this, you can do this. You have to prove it in a randomized study. So at least for the question asked, in PET negative, is there less than a 7 to 10% without radiation? The answer is no. Now, we absolutely need longer follow-up, and of course, towards late effects and overall survival. Then the other question, I've really just shown you the PET negative data. What about the intensification, which officially hasn't been published yet? It will likely in the next few months. This was the PET positive from the ERTC study. So remember, those patients randomized to a different strategy. If you're a PET positive, you changed therapy, or you gave 2 cycles of escalated BIACOP. This was presented at Lugano last year, and there was a statistically significant PFS difference, fairly impressive, of about 15% at 5 years, and at least at Lugano, 0.06 overall survival at 5 years was 7% better. So obviously it'll be interesting to see this data in its final form. So, and there was not a randomization of PET positive for the RAPID. Everyone received a 4th cycle of chemo and received radiation. So you try to individualize it as best as you can. And so for favorable patients, and I still try to split hairs into 2 groups, if it's basically a woman who has central chest disease, again, admitted it's a bias and admitted there's probably a 5% absolute increase in local relapse, I will give chemotherapy alone. If it happens to be a patient with more central disease, let's say like cervical and supraclavicular or something along those lines, I think 2 and 20 is a valid option. For unfavorable, I'll usually, and I should also mention 3 to 4, it'll be closer to 4. and unfavorable, I'll give chemotherapy alone, just because you end up having 4 or 5, 6 sites that, yes, it's involved field, but by the time you give all the involved or even involved node, it ends up being a lot of radiation. What about PET positive? I think we have to see that data. Advanced stage, fair to say outside of Germany, the standard is ABVD. This was the intergroup study that was finally published a few years ago, Stanford 5, ABVD. I'm not highlighting one, okay, there's not a difference, but look how, this is pretty good overall survival. This is all advanced stage. You can see pretty close to 90%, and when you take out the elderly, it's over 90%. I'm going to skip over the BIACOP. I think there still are issues with BIACOP, and maybe there's a high-risk PET-positive patient population, but my bias is still that it is tricky, and there's, I think, some fatal flaws, frankly, in the original New England Journal paper related to dose intensity. So what about response adapted? Again, most studies have drawn the line 3 and 4, so to be positive, you have to be greater than the liver on visual inspection. This was a SWOG analysis that should be coming out in JCO any day. It was not a randomized study, but we basically changed to escalated BIACOP if your PET2 was positive, and at least compared to historical controls. Looks pretty good, not randomized. This is a randomized study in the advanced Hodgkin lymphoma space that also has not been published. It's currently at review at a large journal. And their big randomization was for the PET2 negative group. So in other words, if you had a negative PET2 for advanced stage Hodgkin's, they randomized to the standard for ABVD or dropping the bleo, AVD. And what did it show? Is basically no difference. So I wouldn't be surprised once this gets published, likely this summer, that this will be the, if you're going to give ABVD, a change in this worldwide standard of care, that we will drop bleomycin after 2 cycles of a negative PET. Someone could argue, do we need it at all? But at least this question this study addressed was that. A couple niche subsets, older patients. So we took that same 2496 and looked at about 45 patients who were over age 60, because there was not an age group in that. You can see the bottom falls out. We've known that this is a harder to treat. Is it because of the bleo? Is it a different disease? Epstein-Barr? Is it mixed cellularity? You can see the difference there. Just a one-slide summary. We know it's suboptimal. There are some personalized regimens. Off a study, I usually treat similar to younger, but a priori don't use bleomycin, and certainly need more prospective studies. Gray zone lymphoma, sometimes it gets thought of, and it's very difficult to diagnose. We're still working our way through this. This is basically, came out of the NIH from some of the primary mediastinal lymphoma data that Wyndham Wilson, Kieran Dunleavy, and it's really transitional. It's really, what I mean by asynchrony and morphology and immunophenotype is they'll look like Hodgkin cells but be CD20 positive, or they'll look like diffuse large B cells and be 1530 positive. The long and short of it is that it's definitely worse than primary mediastinal. We did a retrospective review and said, and looked, it was just retrospective, that it looked like you should probably treat this more like diffuse large B-cell lymphoma. Not a randomized trial, but data looked to be twice as good, at least PFS, with that therapy. And I'm not going to talk about targeted, but I want to say what's frontline. With targeted, we're waiting on these results. It has finished accrual for its main study, basically brentuximab vedotin with AVD versus ABVD. So we'll have to see how that comes out. This was published in Blood, a single-arm, single-agent brentuximab in those elderly patients. I would say it really wasn't great, that there was a decent overall response, but a lot of relapses. This study has since been amended, and they're adding back some chemotherapy. We took a different tact and started with the standard AVD and sequenced in brentuximab in a multi-center. It still has a few left to go on accrual, but at least at Lugano last year, looked pretty good. Our overall response and CR rate was 95%, and 95% of patients were free of disease. Was not without toxicity, as you might imagine, including to the BV with peripheral neuropathy. So we'll see how that study finishes. And I'm not going to talk about checkpoint, but I will say, as Dr. Yunus alluded to, we are actively integrating this into frontline therapy. This is a study, another study that I don't know if he knows yet, but hopefully Memorial will do with Northwestern, and we're going to participate. Don't look at the details, but we're actually, to John Leonard's question before, we're actually, because albeit hypothetical, we're going to sequence in checkpoints. So we're actually going to start with a window of 2 cycles of Pembro, then chemo, and then based on age, we're actually going to include the opposite ends of spectrum, early stage and elderly patients that we're going to look at. We're going to sequence it in before and after. So I think it'll be interesting, obviously, to see how this falls out, and maybe brentuximab vedotin should be part of the mix as well. There's just going to let you know there are some really cool other immunotherapies out there. This is another bispecific that is CD30 and CD16. The CAR T cells have a CD30, so they're not frontline yet, but I would imagine the next couple years they will be. There's actually, we know about CAR T. What else is a strong immunotherapy cell in our body? Our natural killer cells. So you can actually make a CAR off an NK cell. So this is also being looked at much earlier days than CAR T cells, but the nice thing about this therapy is it's an off-the-shelf. You don't have to take it from the patient, and you can basically put on whatever antibody you want. There's now, we haven't thought of EBV-directed therapy because we could only construct to latency 3, but now with the advent of doing these vectors with LMP2 and 3, you can now direct EBV therapy in Hodgkin lymphoma, at least for the ones that express it. So, overall summary. High majority of patients with early stage Hodgkin's are cured. Yes, individualized therapy, and continue to study response-adapted therapy and try to determine for the individual patient in front of you what's best for them, whether how much chemotherapy, whether or not to give radiation, et cetera. Arguably, the standard is still 6 cycles of ABVD. I think response-adapted therapy, published later this year, will change that paradigm, at least for PET-negative patients, and we await that phase 3 data as well. Elderly, I would say think about it similarly, but no bleomycin would be my bias. Gray zone, treat as a diffuse large B-cell lymphoma, and if you have a question, definitely get a second opinion. Pathologically, these are still difficult, and it's a very exciting time. I mean, my hope is in our lifetime that maybe we'll have a chemotherapy-free approach for a subset of patients. Thank you.